All right, welcome. Today, we're going to play medical detective. We're going to dive into how doctors think, how they solve these really tough cases by focusing on one of the most complex clues they have, the human eye. You might think a red eye is, well, just a red eye. But to a doctor, it's a clue. It's a message your body is sending you. And the real question is, are we actually listening to what it's trying to say? And that's our big idea for today. Think about it. Every single diagnosis is a puzzle just waiting to be solved. Your symptoms, your medical history, even the things you don't feel, they're all pieces. And the doctor's job, it's to put them all together to see the whole picture. So let's open up our first case file. This one's all about pressure. A mysterious and frankly dangerous amount of pressure building up inside the eye. Let's investigate. Okay, here's our patient. He's a 60-year-old man, and we know he has a history of COPD. Now, a good detective pays attention to every little detail, and bam, right there on that last line is a huge clue. He's on long-term corticosteroids. Let's just file that little detail away for a moment. So the first piece of hard evidence we have is this number, 35 millimeters of mercury. That's his intraocular pressure, or IOP. Now, to give you some perspective, a normal healthy reading is usually somewhere between 12 and 22. So yeah, 35 is a major red flag. If we don't figure this out, this kind of pressure can cause permanent damage. So here it is, the central question of our investigation. This pressure isn't just happening for no reason. Something is causing it. Our job is to find the culprit. All right, so we've gathered the usual suspects. This is our lineup of potential culprits, all different types of glaucoma. You've got your common primary open angle, the really painful acute angle closure, and a few others. But take a look at that last one on the list, the one that's directly linked to corticosteroid use. Very interesting. Time for an interrogation. Let's put acute angle closure glaucoma in the hot seat first. Its MO is a sudden, really severe attack of pain and redness. But when we look back at our patient's file, nothing, no mention of that at all. The clues just don't match up. So the alibi for acute angle closure is solid. It couldn't have been the one. And this is such a crucial part of detective work, right? You have to rule out what isn't true to zero in on what is. Let's go ahead and cross this one right off our list. And this brings us to our real culprit. Remember that key clue from the very beginning? That long-term steroid use? Well, it wasn't a coincidence. It turns out steroids can actually block the eye's natural drainage system. Fluid backs up, and the pressure just skyrockets. Case closed. Okay, on to our second case file. This one starts with a really common symptom, a red eye. But here's the twist. The most important clues aren't what we see, they're what's missing. So let's meet our second patient. She's a 35-year-old woman with a history of Crohn's disease. She comes in with a red, irritated eye and some discharge. Now, on the surface, this seems pretty straightforward. But remember, a good detective always looks deeper. And here's a brilliant piece of detective work for you. Sometimes the most important clue is what's not there. The absence of a symptom can be even more telling than its presence. It lets us eliminate suspects with a ton of precision. So here's what's missing from her story. She doesn't have any of that severe, deep, boring pain. She's not experiencing photophobia, which is that really painful sensitivity to light. And, most importantly, her vision is fine. This missing evidence is exactly what's going to guide us. This table really decodes all the clues for us. You can see scleritis and anterior uveitis, both potential suspects. They involve severe pain and vision changes. Our patient, she has neither of those. Her symptoms, mild irritation, no vision changes, they point directly and clearly to conjunctivitis. And there's our verdict. It's conjunctivitis. It fits the evidence perfectly. The symptoms that are there, like the redness and irritation, they match. And just as important, the severe symptoms that are absent let us confidently rule out those much more dangerous possibilities. So, we've cracked 2 cases. What's the big takeaway from all this? What have we learned about how to read the clues our own bodies are giving us? It all comes down to this. In both of our cases, the mystery wasn't just solved by the symptom that brought the patient in. It was solved by their full story. The steroid use in the first case, the lack of severe pain in the second. Your medical history isn't just background info. It's the most powerful tool in any diagnosis. So here you go. Here is your own detective's toolkit. The next time your eyes try to send you a signal, use this list to gather the clues. Be specific. Is the pain mild or deep? Is there discharge? How's your vision? Is light bothering you? This kind of detail makes you a real partner in solving your own case. And that's the question I really want to leave you with. Now that you kind of have this framework for thinking like a medical detective, what clues are you going to notice next time? Thanks for joining me on this investigation.